Welcome to this episode of Orthodontics in Summary. Today's podcast episode is looking at Paediatric Obstructive Sleep Apnea and how this medical specialty seems to be entering into orthodontics. This episode is based on two excellent lectures by the giants Flores as well as Alberto Capriglio. Just to recap, the podcast is a opinion piece of myself and the Orthodontics in Summary team. We try our best to ensure it's as accurate as we can, but may not 100% represent the original lecture. So why has paediatric obstructive sleep apnea become a conversation within orthodontics? Well, obstructive sleep apnea is defined as an upper airway dysfunction. The pathophysiology is relatively straightforward. There's an impairment to the patency of the upper airway. This results in an increase in serum CO2 and a reduction in oxygen. The chemoreceptors result in a state of arousal for the pediatric patient, making them awake to a degree, forcing the airway open, and this cycle of sleep disturbance continues. So why is this so important to the growing patient? Well, it's down to the slow sleep wave, a constructive phase during sleep, where growth hormones are essentially secreted, glial cells within the brain are restored, and it helps the patient to grow. This is seen most evidently in the consequences to patients with pediatric obstructive sleep apnea. There are delays in development, growth. There's also poor academic performance, indicating the cognitive effects that take place. Aggressive behaviour are part of the multitude of effects of pediatric obstructive sleep apnea. So how is it treated? Well, it's a medical specialty, it's diagnosed medically, and it is treated initially with first-line surgery of adenotonsillectomy. Prime etiology when it comes to obstructive sleep apnea is hypertrophic adenoids or tonsils. The second most common cause is a lack of muscular control and tone. Now, the reason why this conversation enters into orthodontics at this stage is because after the surgery, 40% of patients still have residual obstructive sleep apnea. And the question really is, can orthodontics be the solution to either resolve this 40% or indeed be something that can prevent surgery in the first place? So what are the treatments within orthodontics? Well, the airway is subject to two components that are under the orthodontic influence, that of the palatal shelves through expansion and also advancement of the mandible. So starting off looking at expansion to begin with, the theory is pretty simple. The roof of the mouth is the base of the nose, so if we increase the roof of the mouth size, the base of the nose also increases in its size and therefore the volume. And this can result in a reduction in obstructive sleep apnea if the obstruction is in the nasopharynx. So what has been found out? Well, it is effective at reducing signs of obstructive sleep apnea using the apnea-hypopnea index by 20%. And that's for the majority of patients, over 85%. That's Villa's 2015 study. Now, Flores dived into this deeply. He said actually a 20% improvement is not significant in terms of medical improvements in terms of disease. Actually, 50% is defined as that minimum. Worryingly, looking at the same data from Villa's 2015 study, it showed 15% of patients actually got worse. And it wasn't curative. Actually, 60% of patients still had some form of obstructive sleep apnea left at the end. So what we're building is a picture that expansion can result in a reduction in obstructive sleep apnea, but it doesn't cure it, and it's not for every patient either. Now, Alberto had some really good insight into combining expansion with vitamin D. Now, vitamin D actually has treatment modalities for patients with muscular function weakness, as well as patients who have a low immune system. So actually, patients who had vitamin D combined with expansion seem to have better long-term resolution to the obstructive sleep apnea. When it comes to looking at mandibular advancement, the theory is the mandible is moved forwards and the tongue moves with it, therefore open up the space posterior to that, i.e. the oropharynx. This increases the oropharyngeal airway space and volume and also reduces the collapsibility. There's a proposed physiological role here, which stimulates the dilation of the upper airway muscles, improving the strength and control. So this is the theory. Now, Yun-Yun's systematic review in sleep showed that actually, when it came to using a mandibular advancement appliance, there was a reduction in obstructive sleep apnea. The AHI, the apnea-hypopnea index, reduced by 1.75, which is only a modest improvement for it. Interestingly, in the paper, they also described the long-term requirement for this. And this really begs the question, can we have patients long-term as pediatric patients using mandibular advancement appliances? The next question is, can we work out which patients will benefit the most from this? Are there craniofacial features we can diagnose and screen as orthodontists and therefore locate the patient who will have benefit from this? Carlos Flores as well as Fagundes in 2022 looked at this in a systematic review and found, unfortunately, there was no correlation between craniofacial features and obstructive sleep apnea. Confusingly, the following year, 2023, Wang and Liu had a systematic review which did show there was differences in craniofacial features which resulted in obstructive sleep apnea. Now, there's a difference here between these two systematic reviews, which is confusing. There was an excellent point-counterpoint, the Journal of Clinical Sleep Medicine by the two author groups, where they came to the conclusion that actually using a sleep study, polysomnography, may underestimate the presence of obstructive sleep apnea, but using broader criteria, for example snoring, may be too vague and may overestimate the obstructive sleep apnea which is present. So we're building a picture that even defining the disease is unclear. To conclude with, I wanted to describe to you the American Academy of Dental Sleep Medicine's consensus statement from this year. And it looks at the treatment modalities within orthodontics, starting off with expansion. There was no consensus whether it could either prevent or be management for obstructive sleep apnea. There's difference of opinions, there is evidence that's there. Interestingly, there isn't enough evidence to state if it could be a cure for it. When it came to mandibular advancement, there's even less information, and it's unclear if it can even carry out preventative measures, be involved with management, and indeed be curative. If you'd like to hear more about obstructive sleep apnea, please check out my last interview in Orthodontics in Interview with Sanjivan Kadasamy. We spent a whole hour deep diving into obstructive sleep apnea. That brings me to the end of this episode. The last week it's been busy. I was at the British Orthodontic Conference having the pleasure to host Carlos Flores as part of our studio sessions. I'm really excited to see some of his research coming through as well as Alberto's in this topic as we try to understand where does orthodontics fit in. Hope you've enjoyed today's episode. Please do subscribe and look forward to our next episode.